Welcome everyone. This is Caleb at Task at the National Rural Health Resource Center. This is the second presentation for the Advanced Payment Model Learning Collaborative 2.0 or 2.2. Reminder to please dial into the audio portion of the webinar and unmute your line utilizing *2, as all of your phone lines are muted via default. We'll get Shannon's slides up there. As you join, we have a little polling question here to check on the presentation time for next week. And it looks like 2 p.m. Central does work best for everyone. So we'll get a notice out and send a polling question out just to make sure. But it looks like everyone 2 p.m. Central does work best for everyone. So we'll get that changed as we had it set for 12 Central. I don't have any further updates or reminders, just a reminder that next week the Task 90 webinar is scheduled for Thursday the 15th and not Wednesday the 14th, and that will be 2 p.m. Central, and it's focused on COPD and all of the new and exciting resources that we've been working on. Shannon, I don't want to take up any more of your time. Any questions or anything, please utilize the chat feature or unmute your line via *2.
Thank you, Caleb, and welcome everyone. As Caleb said, for this week 2 of the 6 weeks webinar series for the Learning Collaborative 201 for Flex Coordinators. This week, I'm calling this the paradigm shift. And as noted, thank you again to the National Rural Health Resource Center for hosting this and allowing me to share with you thoughts and ideas in regard to the state of affairs and transformation, specifically related to rural health. This, of course, aligns with the Center's 5 core areas that we spoke of last week. This week, I want you all to remember that the intention of the series is really to help understand the components of healthcare transformation. And this particular week, I'm trying to focus not only on the Medicare component. We also want to look at how transformation affects critical access hospitals and rural health clinics, and then hopefully provide some tools and resources for the providers to engage in transformation along the way. I do encourage you to participate by chat box, or if you'll just give a quick note, I'll be happy to open up so that you can ask a question as I'm going along. What I'd also like to note is that I may drift back and forth between speaking to you as Flex coordinators or speaking specifically about the message to rural providers. Also, I intentionally leave quite a bit of material in the slide deck rather than in the notes as reference for you if you're able to use this information. So again, this week I'll touch quickly over the webinar series and what to expect after this week. Specifically this week, I really want to look beyond Medicare and what that impact is, what I would call the element to manage a paradigm shift, and then we'll start working on the impact on rural health. So with that, let's look briefly at the series. Last week we talked quite a bit about CMS's intentions and how they lead the change through payment and delivery reform. This week, we'll try to look at a bigger picture than just Medicare. And then the next 2 weeks, we'll look at accountable care organizations and other pay-for-value programs and how that relates to opportunities and barriers for rural providers. Following that, I also want to take a look at clinically integrated networks and what that can look like counter to accountable care organizations if the barrier is too big. I also will speak about how to win against the tyranny of small numbers. I think everyone in rural knows that, but maybe they don't phrase it that way, so I'm looking forward to sharing that thought with you. And then finally, really talking about how do we paint the picture for everyone who cares or is interested to buy health care from rural providers in the 6th series. So let's move on to the paradigm shift in healthcare transformation. Merriam-Webster's definition of a paradigm shift is an important change that happens when a usual way of thinking or doing is replaced by a new and different way. I feel pretty confident that we are pretty much in the middle of a paradigm shift. At the minimum, we're at the discovery phase. If we look beyond the work of Medicare and the Transforming Clinical Practice Initiative and the Centers for Medicare and Medicaid initiative, you can see in the 2017 Commonwealth study, which is the basis of a lot of work that we're seeing done, that this actually included survey to measure and compare patient and physician experiences across wealthy nations, and it ranks the U.S. last overall, and almost out of every specific area that they measured: care process, access, administrative efficiency, equity, and healthcare outcomes. The U.S. is last in all but one. Well, two, but it's next to last in one, so that's close enough. And I think that's pretty astounding if we're not just talking about bending the cost curve as we did in Medicare, but we're talking about the care process, the ability to get access, how it's managed in a system level, and that's across not just providers, but providers and payers in the government. And then how is there equity for all? And of course, that is tied to what we've seen, which is healthcare outcomes. So this is a national issue that goes beyond Medicare, and it's measured worldwide. It's significant. It is embedded in all the work that we're doing, and you're probably seeing it in a multitude of places. I was lucky and fortunate to participate in what was called the Initiative 1811. It was founded by the Kaiser Family Foundation and the Society of Actuaries, who they are one of the leading worldwide entities that do actuarial studies on healthcare. Originally, this initiative was called the 1710 Initiative, but as it was forming, it actually grew against the gross domestic product. And what the point of this slide is that compared to all other wealthy nations in the world, the U.S. is exponentially spending more and not getting as much return on the spend. And this, in connection with the previous slide, shows that something is not consistent with what we're seeing. I thought it was very interesting to compare this slide to the previous slide, that this one is looking at cost, and we've talked a lot about spending and cost, but we haven't really spent a lot of time looking at how we're ranked in care process, in administrative efficiency, equity. We've done some in healthcare outcomes, so that's part of the triple aim, cost and quality, but all of those others we really haven't seen measured. Not a lot anyway. There's one other very interesting thing that I found that it was important for us to consider, and that is the numbers that we looked at in Medicare were sort of an 80-20 split of those 20% of the senior population that takes up 80% of the cost. But that's expected with those that are aging and with a lot of density in the chronically ill numbers. But there is a whole other conversation. It's called the 550 population, and that was actually out of an ARC study that said that the cost of health care can be attributed to 5% of the population. 50% or half is attributed to 5% of the population. They called this the chronic disease burden. And again, if we look back at the work that was done in Medicare, we can see that there's a big focus on chronic disease and how do we manage that. And then again, looking at those MIPS numbers and what they're measuring, it goes to the process of catching the disease state before it advances to very costly long-term in-hospital stays. So these three slides really make a point that it's not just Medicare. Medicare's big and has a lot of volume and certainly a limited time to bend the cost curve, but this is happening across the country and across all payers and providers. The other thing that I've been watching this for a little while, and there is significant demographic changes that I think will create a difficulty for rural providers, and I'll explain that. We've talked before about the baby boomers entering the retirement age, which grows exponentially the number on the Medicare roll. But counter to that, we are actually seeing millennials and other young cohorts seeking health care through technology. The result is that there is a significant growing divide in consumer demand for the type of delivery that we're doing. We didn't talk about that a lot in Medicare, but we're seeing that there's going to be this big difference between the aging population with complex chronic conditions that require long-term management of diseases and young or tech-savvy of any age group that measure value through convenient access to primary care and wellness. I would also say that last is not just of the beneficiaries or patients, but you would also see that measuring value through convenient access in primary care and wellness is probably an initiative that we see in the payer community or the insurance community as well. And my concern for rural providers is that when you're small and your infrastructure is based on low volume, it is very difficult to deliver different types of care for different types of population. And we've seen that in the difference of how Medicare wants you to treat a patient versus how Blue Cross might want you to treat a patient, reporting mostly not so much in treatment, but what is covered in the beneficiary plan, and then how that reporting goes back to that provider. But when we get to a point that it's a significant difference in the delivery based on a culture of the chronic disease community, and then of those that are really connected on technology, there really needs to be a serious consideration of how can we align that? How can we actually align the work across all of that to be very successful? And so let's talk just a little bit about that. I think that really expands the conversation of, again, what I would call the paradigm shift. And fragmentation of healthcare leads to additional costs and duplication of effort. This applies to both providers and payers. There's actually a whole study of clinical variation and the inefficiencies of clinical variation, and it creates a lot of cost and duplication of efforts. And so that goes against the grain as well of what everyone in the country, both providers and payers, are trying to correct. And so what I would say the state of healthcare is that its current state is not sustainable, and that might be stating the obvious, but I really wanted to put some meat into that as to where that's coming from. Early on, when we started talking about value-based payments, there was a lot of resistance in the provider community that it wasn't here to stay. In 1997, we talked about withholds and capitation, and it really didn't stick very well. But I don't think the stickiness is going away in this. I would argue to say that we're in a discovery phase for the providers and the payers to find the quote-unquote stickiness of the payment and delivery reform that still maintains a really high-quality delivery system. So yes, we're in the discovery phase. I would say that it's currently referred to as transformation. What we see today isn't going to stay here forever. It is transitional. And I would try to highlight the point that this is not just a payment methodology, but it is very important to note that it is about changing the delivery as well. And I would say to you, the experience that I had in the field was that it's really difficult to just focus on the payment without getting a shift in the delivery as well, and vice versa. But if you're going to want to get paid in the future, you're going to have to change your delivery methodology. It's pretty significant evidence that that is the case. I feel the shift is really moving us from reactive care, transactional care, waiting until the patient comes, treat them, and diagnose and treat them and send them home, and then wait until they come again, hoping they'll come back in a certain time. We've never been paid before in the white space outside the four walls of the practice and outside of the four walls of the hospital. And so we have to now see that the shift is going to be proactive care, and evidence is that we're actually getting paid for chronic care management, behavioral health management, transitions of care. Those are sort of white spaces out of those four walls. And we're moving to a point where it's not information produced by each provider in a silo. It's more about patient-centered care, patient-centered data, and teams centered around the patient. So that goes from transactional payments to outcome-based payments. And I do believe there is a great opportunity to be successful, and hopefully we can find that in the next 4 or 5 weeks. This really requires that there has to be a significant new way of thinking. And this is a brief chart looking on purpose, value, methods, and assumptions, going from traditional care of really curing a disease to thinking about keeping people healthy. I think that's what providers always wanted to do, but payment forced them to spend a lot of time on managing the disease. Maybe curing and managing the disease is a better way to do it. The values were based on diagnosis, treatment, and cure, with a payment on volume of services. And today we're moving to a point of prevention and wellness. Hasn't been paid for up until this last initiative started in like 2012 to 2015 was really got off the ground. And then quality and cost-effective services. We're moving from fee-for-service into value-based payments. Yes, fee-for-service is still here now. It remains to be seen how long it will be here or how significant it will be if it is here. I would tell you I don't believe that the opportunity to increase revenue is going to sit in fee-for-service. It's got to be connected some way in value. And the assumption before was that the doctor was the center of authority, but I think that's going to broaden to the point that the doctor is the center of the care team. The primary care doctor might be the center of authority, but it is the doctor who is the center of the care team around the patient-centered care. Very significant changes, a new way of thinking. I can guarantee you that the payers have a new way of thinking, and if you've never looked into what the way premium dollars chopped up, this is a great example of this. I remember looking at this probably in 1996 or 97, and it was in the 70s that the medical budget was a percentage of 70 cents. I said in the 70s, it was 70 to 75 cents on the dollar. That was medical budget, sometimes maybe lower than that. It's creeping up, and it's requiring that the payers be much more efficient on all of the other things they do besides the medical budget. Medical budget is the part of the premium that actually pays the medical bills that the providers, the claims that are sent in by the providers. And so this is forcing them to rethink it. So they are having a new way of thinking, and that is impacting how you get paid, and it will impact how you deliver care that's important to them. So what are we thinking? And when I say we, I speak from a rural perspective. This is some observations of what I've seen in the field, but I would assume that we're thinking we provide a service and we get paid, right? Well, has that changed? It's going to. What does it look like? We don't know. What services do we provide? Is that an opportunity? I think yes, perhaps. How do we get paid? Is there going to be a difference in what is the rural designation opportunity in the future? We haven't really heard about that. We don't know how that fits in the space of value-based payments, so it's a real interesting unknown. We think that we are different. I've heard this many times before in negotiating with rural providers, and I've even said as late as a month or two ago to a Medicare Advantage plan, yes, we're different, and yes, we are small, but, healthcare is local, and the answer was, if it's not of high quality that I can't see demonstrated, it's not significant to me. So are those things that we can continue to think that we are valuable because we are different, because we are small, because we are exempt? And I would say if there's this other concern of Medicare Advantage moving some of your patients that are Medicare fee-for-service that sit on the cost report over into things that are not sitting on the cost report, Medicaid moving that way, the work needs to expand into the commercial side as importantly as it does on the government side of payments. And so we, across the board, need to focus on how we are valuable to all of those payers. Very interesting times for us. I've said this before in a slide. You're probably going to see this every week. I can't tell you enough how much I think that it is important. People in the future are measuring differently of how they buy health care. And we'd like to think that our local community buys from us because we're there. But they are moving to a point with information to be able to determine what they think value is. And it's being put out there, and they're determining what the value is, not us. I did a little bit of a research to see what is the published belief of rural healthcare value. And I saw a lot of information about rural health is valuable because they're the largest employer in rural communities, or all healthcare is local. But I didn't see anywhere how rural healthcare in the aggregate can provide healthcare that is highly sought after and valued in the country. I think we can achieve that, but we must be able to reflect that story in our data. It's really important. So you might think this already, and I certainly do. It certainly is overwhelming. There's a lot of ways to think about change. It's overwhelming if we're talking about it in its entirety, as opposed to going about doing business on a daily basis and picking one thing and making that one change. You know, the questions are, what's the right vision, the trajectory, the right plan? We're really on the bleeding edge of this discovery phase of the shift. And so it's not clear to know what the right plan is. You really don't know what the effect is on your local market. And we all know we've seen one rural community. One may be very close to an urban center. Another may be close to a large employer, but nowhere close to an urban center. One may be really a frontier piece. And so the effect on the local market could be very different. But I don't think the consistency of knowing how to state your value changes from any of those variables. I also think we need to watch on how that really affects the rural designation and payments. I don't know what the answer is there, but I do see this erosion on the doing payer contracting, that a lot is moving off of that government component of your revenue payer mix to the commercial side. And so we need to be really astute at addressing the commercial side. We've been great at the government side, but we need to get really good at the commercial side of selling ourselves. So I've put together a list of what I perceive as managing the paradigm shift. In other words, what are the things that you would consider that you could sort of align across the board of how to be able to be very successful in transformation. This includes risk tolerance, legal hurdles, information technology, and all that brings. We'll talk about that in just a sec. Population health, your market assessment, what your provider mindset is and what your relationships are, and then really your current state in the evolution of transformation. So let's dive into what all of those areas are and how that affects you. So the first thing I noticed, and I managed for 20 years a collective of up to about 13 hospitals. It ranged from 6 to 13 over the 20 years, and I worked negotiating payer contracts with them. And as a collective, there's several things that you need to think about. This translates even if you don't work into a collaboration, because you are now focused on making changes in the entire health community within your own town. So that requires risk. There is risk, and not just risk from the financial side of when we talk about in an ACO or a payment methodology, the risk of having to pay the government back, or the upside risk of receiving some extra payments other than fee-for-service. But the risk and change. What is the risk of taking the change? And counter to that, that's almost more important, is what is the risk in not doing change? And I think that I would say to you, you need to consider what would happen if you don't do the change. What is your direct trajectory today? And of course, now I'm speaking directly to the rural hospital providers, but the consideration for what is not changing, what is the risk of not changing? And I think it's enormous. Talking to the payer Medicare Advantage plan in the Northwest, my question to her was, well, yes, rural healthcare is local, and she said Medicare Advantage has just been approved to have the ability to bypass rural providers or any providers by sending them an Uber or a taxi or a driver, picking them up and bringing them to an in-network provider that meets our quality standards. And okay, maybe the technology doesn't work, but 5 years ago I met with Blue Cross Blue Shield in Texas, and they had created an entity called, it was their quality network. They didn't even negotiate with providers for this. They went out to publicly available data like Six Sigma, Lean, and NCQA measurements, and then so publicly available data, rated the providers that were in their current networks, and then those that met criteria on those measurements were then put into a blue ribbon network, dark blue, light blue, and clear. And what they told the beneficiaries that were in Blue Cross was that you might have a better deductible, you might have no copay, and maybe your premiums will change if you start using one of these blues. Rurals didn't fall into it because a lot of those publicly available data things didn't really apply to rural health, and it certainly didn't apply when you have low volumes. And so they just bypassed without even talking to anybody about it at all. It's frightening to know that if we're not paying attention as an aggregate of rural health about what messages we're sending or not sending, so the risk of no change is incredible. There is risk in collaboration, and by that I don't mean that there is a negative risk, but there is new relationships that might create new liabilities. You certainly have to pay attention to START. Sometimes there's stark waivers in the collaboration, either with neighbors or with providers in your community. So there's a risk tolerance that you have to really have a good sense of. I would suggest that most of CEOs in critical access hospitals have a good sense of the risk of collaboration, but they would want to know how high or low that risk is in order to push an idea to move it forward. And then, of course, we know about the risk and payment methodologies of upside wins and shared savings, or the losses and downside risk. So it's important to know the risk tolerance. Even the risk tolerance at the board level, there may be a significant amount of work and leadership training that has to happen at the board level to really understand where we are in the state of rural health and the changes that need to be done. So the question to manage the paradigm shift would be, what is the risk tolerance in your community, and what can you do to garner support for change? And the second one would be legal. Aligning the healthcare community could require that there are changes in legal structures or relationships, or even development of new organizations. For instance, you may have other practices in your community, even if you own the rural health clinic. You may have a rural health clinic in your community that you don't own. But if we're moving to value-based payments and outcomes, it's critically important to align that, because the primary care provider is going to be the one in the driver's seat that sort of manages the referrals and where the data is coming about that whole component of prevention and wellness. So if we have the ability to manage and collectively align for the prevention and wellness documentation, then we have a really good ability to have a great data story. So do you employ your physicians? If you don't, should you? If you do employ them, is there a payment for value in the physician contracts? How does that affect the RVUs in their contracts? Are there new services based on prevention and wellness that once you get into this, you can recognize that might be a way to actually grow on the ambulatory services side? Rural practices, rural hospitals are really already set up to do this very successfully, I believe. I think the numbers have been a CAW, RHC collectively is about 75% outpatient and 25% inpatient. As things move to ambulatory work, there's a great opportunity to continue to build on that model that's already been very successful in that model of CAW and RHC. The other thing is that there might be some existing solutions that need to be retooled or updated. Perhaps the alignment of a wellness and prevention center that sort of helps expand the primary care in the rural health clinic, or even a fee-for-service clinic. There's several things to consider in that regard. And then finally, what is the most valuable solution for your plan vision? What is your overall plan vision for your community, and how can you form the proper legal structures around that? I don't think it's any surprise that information technology is probably the new partner to dance with. It hasn't been all that new, but it has certainly been continuing new on a regular basis of the importance of it. Data analytics are the new component. Having the ability to have data and then understand what the data says about you, and then do a lot of working to continuously improve with the data that you have to get more data to continuously improve. That's a whole new set of work for providers, and I think there's some opportunities in collaboration. I would tell you that that's one of the gifts in working in an alternative payment model with Medicare, is that they give you claims data, and all of a sudden you can see the story of your patients that you've never seen before. So I think that's an important consideration in having access to learn under a payment model before there's 100% risk in downside payments. And that's rapidly going away. But information technology, you really need to consider what components you have in place. Do you have providers that are not using EMRs? There is little time to be able to get them to turn around in it. And if that's the case, how can you help them if they have a great patient base? How can you support them? How can you support retaining that work in your community? Based on the data and that population that's with that practice. Would you have to purchase a new technology system even for yourself or for that practice, or would you need to just buy a module to extend on it? And then if you're going to get into the point of doing some analysis on data, do you have partners that you can work with? Can you work with a subset, and how do you do that? Now that's a lot to chew on, and I don't know that any one individual entity really has the wherewithal to do that, and we're going to talk more about that. You get that out of an ACO, but maybe in some other types of collaboration arrangements, there might be some really great opportunities, and rurals are really great at doing that. So then population health. I don't remember how much I talked about that last week, but population health is the opportunity right now. It's harder in a rural health clinic than it is a fee-for-service, but I'm going to tell you, management of the cost curve, documentation of what happens in a full annual wellness visit and not an annual physical exam is critical to the ability to document and demonstrate value in the story. Engaging in chronic care management is the other way to be able to demonstrate value and bend the curve by managing the disease states of the patient and expanding the rural practice in getting the right balance of physicians with nurse-led care. So I can't say enough about how important population health and prevention and wellness and a population health strategy is. It is the beginning tip of the spear for the success of the value story and for being able to manage the patient, sustaining your physicians and their ability to deliver the care through nurse-led programs. So this one's really critically important. And then market assessment. We haven't talked a lot about this, and sometimes difficult with rural providers depending on what their payer mix is. But I think it's really important to start watching the trends of the payer mix. How much is moving to Medicaid managed care? How much is moving to Medicare Advantage? How much of commercial payments are really affecting your market share? And are any of them doing value-based programs that you don't qualify for? How will you manage, I said the reduction of government fee-for-service. I see that as an erosion across the country. I don't know what the result would be in that for rural health clinic all-inclusive rates, but it will be interesting to watch and see. I think regardless, we don't see anything from SEMA Burma and CMS saying they're going to back off of paying based on value. So we must demonstrate our value. And then the new conversation is really what's the demographic trend in the next 5 to 10 years. I was working with I would say, a large rural community recently in an oil field area, and their demographic change is going to be 150,000 new people moving in, and they're not going to be seniors. They're going to be a lot of people who need on-demand out in the field. That's almost doubling the community in size, and so it's really fascinating to watch that demographic trend. Not that that applies to everyone, and not that it would be that dramatic, but I think that it's very important to have a vision of this divide of delivery type 5 years down the road and 10 years down the road. And then what responses will you have in your change to payer mix, and how can you start to align your payers' requirements? Can you start to see the workflow and the process of this new value-based proposal across payers be worked into a consistent manner that raises your value story, and you're able to manage from one place rather than what I've seen we've done for years is adding new hats but not changing our ways, just adding more and more, sort of going horizontal instead of vertical in growth. We really need to rethink that and start thinking about maybe retooling it as an approach to everything for value. And then the other really important thing is that the physicians and practitioners are probably the #1 most impacted people. We hear a lot of conversations now about provider satisfaction. I actually have seen that is the quadruple aim, adding into better health, better care, lower cost, to include provider satisfaction. And we hear a lot about provider burnout. We all know that it's really hard to recruit practitioners to come into the rural community. And so how do we actually manage the stress? They've been going through PQRS and meaningful use and now value payments and the adoption of new reporting. And now we're asking them to actually think about, doing care planning with nurses and nurse-led population health programs. So what's your message? What do you think the pushback is? Do you need outside help in that conversation? And how do you collaborate across the community with your providers? Then do you need to align with them through contracting? Do you need to change their contracting, much like in the legal conversation? Do you also need to build a new relationship? And if you don't have one that's agreeable in your community, and I know some hospitals do have that problem, then how do you manage that in this new space? There might be some new opportunities to have a better relationship based on that. So one of the encouraging things is I think that based on the current state of the healthcare systems in this transformation, in the evolution of transformation, you can jump in any time. But I think the sooner is better, and I think that it's critically important that it's going to accelerate, that Medicare is leading that charge, and we've seen that there's a sort of a cliff of requiring risk by 2026 and fee-for-service payments. Hopefully there'll be some solutions for those that under their discovery period didn't fare as well, so they keep a little bit of fee-for-service, but I'm not going to suggest what that solution will be. But it's really important the sooner the better to get into some type of value-based program and work on your story. You would want to know how capable is your system to be able to manage the shift across it all and this new way of thinking, and then be able to demonstrate your value. Can you do that now? And I mean value not of what it means to you or just your community, because commercial payers really don't know about your community. They know the metric nationally for what care is. So that's something to think about. The new way of thinking. I read an article, and I'll explain that to you, but I think that there's an opportunity to shift from just being a provider reactive. So we've been asking our physicians to be different. We've been retooling a little bit. but we haven't really thought about us in entirety as a collective of being a product instead of a platform. And so the new way of thinking could be that you could deliver health and healthcare for your community than providing services. That sort of moves from that transactional care into care based on value. And let me explain that just a little bit. I was reading a Becker's article, and it was actually an IT person who attended one of those Becker's conferences. This was probably around in February or March of this year. And the observation from the technology person was to listen to one of those shotgun rounds where maybe 25 CEOs of healthcare systems get about 5 minutes each to talk about where they feel and things are going and how they're going to actually manage this paradigm shift. And this is a quote from the article, but it said that healthcare providers are moving from traditional strategy of buying and building hospitals and simply providing care into being more dynamic, leveraging the platform they have, and then place it, they have in place, and then create it to more value and growth and new profitable streams of revenue. A new way to look at that is leverage the platform and the resources, but create that to be a hub for both health and healthcare of the future. And by what I mean by that is that you have the bricks and mortar, but there's a lot more to offer in bricks and mortar. I've seen over the years and more recent than not, where prevention and wellness becomes a whole another product on the platform. As technology comes forward, there'll be other products that you can offer that you haven't been able to do before. Behavioral health through telehealth is one of those, and there could be others. So sort of like the world is, technology is a flattener from the book The World is Flat. You do have opportunity to make this shift, but it requires a new way of thinking. And what my point for today's presentation is really the observation has been we've been sort of taking it in bite-sized pieces, but still holding on to the fee-for-service ways. And the reality is this shift is affecting everything all at once. And it's really hard with a narrow infrastructure to approach it incrementally over time, because it's really hard to spread yourself that thin. So at some point, you need to start thinking about how its entirety and what the vision is in the future, how that's going to affect how you get paid overall, how the healthcare is delivered, how technology is really critical and you need to buy into that. And then what do you want it to look like in the future? What's your data story? What's your value story? So this really requires a new way of thinking about everything. That's really a big chunk to bite off, but I think it's going to require that long-term thinking rather than head down getting the job done, and that's going to be a hard lift in the future, I think. So getting close to wrapping this up and hopefully not delivering a lot more to digest, but what is the rural option? And I would pose to you, I don't have a solid answer on that, but hopefully we can start exploring that in the next pieces. One of my favorite things that I've found over the years, and I found this in the Peter Congbelt's book called The Managed Care Handbook. It was written in 1995. I think I read it in 97. And it talks about virtual integration. And it's funny because the network that I worked, I called it a virtually integrated delivery system. And my husband always said, what the heck is an executive director of a virtually integrated delivery system? Sounds kind of interesting to me. And it was very interesting. But what this says is virtual integration. Each of the major segments of the healthcare system, physicians, providers, and ancillary providers, as well as managed care organizations, act in concert for a common cause, but none is an employee or a subdivision of the other. This allows the parties to manage its own affairs and meet its own goals financially without being managed by any other segment of the industry. In a way, the ACO that you see today really is a type of virtually integrated delivery system. In a way, a lot of those rural networks that we see that have been long-term standing out there across the country could act as a virtually integrated delivery system. There could be regional providers that aggregate under a payer contract and still be able to leverage what's important to them in connection with the payer. I think we need to be thinking in these terms in order to be financially successful and sustainable in the future. So we'll talk about that in the ACOs under this context, the other alternative payment models, as well as clinically integrated networks in the next session. So with that, I'll pause to take questions. We probably have about 15 minutes, maybe a little less. Are there any questions, comments, thoughts? Maybe Terry, if you're on the line, you could speak to if you've heard anything in regard to the rural designations, and is there any value-based payment tacked onto that yet?
I'm sorry, Shannon, could you repeat that?
I said, have you heard of any rumblings that there is conversations about the rural designation payments, like all-inclusive rates, being connected to value-based payments, or an opportunity for rural providers to engage in value-based payments other than the standard ones that we see?
I think there's been speculation on that from what I'm understanding. One of the things that seems very clear to us is that CMS and CMMI pretty desperately want rural hospitals to kind of move into value and population health. And as I think you've mentioned in the past, the AIM program actually provided them with startup funding, et cetera. And just given the current political situation and what seems to be some pretty significant support for rural hospitals, concerns about that as well. I know it's on CMS's mind, and as I think you've already indicated, the biggest stumbling block we face right now is the whole question of risk and the reluctance of rural hospitals to kind of move into that sort of an arrangement. So we're hopeful that there are going to be certain provisions that would protect our rural hospitals kind of moving forward, but nothing that I can see that's on the immediate horizon here. I also just want to say that I really, really agree with what you have to say, Shannon, on this. I don't think we've quite discussed what one of the speculations is that beyond these accountable care organizations, we're going to move into kind of this global budget, kind of all payer sort of an arrangement. And I don't want to get ahead of you on this sort of a concept, but that starts to create more incentives like the Pennsylvania model, where rural hospitals are able to participate. In fact, they're the major players here, and that kind of gives them the ability from a financial standpoint and from perhaps from a risk protection standpoint to be successful. So those are just a few thoughts that I have on this.
Thanks, Terry. I appreciate that. And yes, we do need to talk about the Pennsylvania model, but I appreciate your comments in regard to where CMS is. I think we have the opportunity in the current climate of the offered pay for performance model to be able to demonstrate our story, but that time is getting away, and I think Medicare would listen to us if we had a story in aggregate. So there's a window, I think, that will evaporate in the next 3 or 4 years, I think.
Kind of in regard to the private insurance organizations, we've had some recent recommendations coming out of our latest summit meeting, which really speaks to the recommendation from our summit participants that hospitals start to develop strong relationships with the private insurance companies and other third-party payers. In essence, they're primarily funded by Medicare and Medicaid, but it's pretty crucially important that they be able to kind of understand the payer perspective, before we go hat in hand and ask them to, work with us, et cetera. The recommendation that came out of our summit was that we really need to get to know them and need to know what their motivations are. And I couldn't agree more with you, Shannon, that the bottom line is going to be, if you can show me value, if you can, hold down costs and you can show me quality, then in essence, our Blue Cross Blue Shields of the world are much more willing to include our hospitals in these models that they have. And I share your concern that if hospitals are not capable of doing this, we may very well lose a great deal of money and maybe even be excluded by some of our more private third-party payer organizations.
Right. And converse to that, I really believe there are so many of the components to be successful in what payers want that exist on the campuses of rural hospitals and the providers in their community. It just requires this new way of thinking. I think the opportunity is to be able to think outside of the box and really, because we're small, we're nimble, we should be able to become the coveted delivery system. We should be able to create high quality in short order.
I don't want to be a yeah butter here, but I'm going to yeah but. This is Scott Daniels. One of the issues that we're having, and Hawaii is lucky in that we don't have 1 million different payers. We don't have 1,000 in comparison. So, but the thing is that there's no one plan. Even CMS has no one plan, and so everyone's doing something. And so our small hospitals, which are nimble, are supposed to somehow implement 5 different payer plans at the same time. Medicare is doing something, Medicaid is doing something different, the Blue is doing something entirely different, and then the private payers are doing each of them are doing something different. And it's the only reason it's on the top of my mind, I had to miss last week because I was at a quarterly meeting, and it came up at the quarterly meeting, how many different things they're trying to keep track of in order just to make payment. And it's not that there's not a willingness to move down this route. It's just that it's taking so much time because there's not a set plan. They don't know which plan to do, and they have to do all of them in order to get any payment. So.
Right, and I appreciate that, and I do know where you're coming from. In the last couple of years, we actually, when I worked for Practice Transformation Network, we realized the interesting balance of payers in the Hawaii market. What I would suggest, I would like to suggest, is that there is probably a consistency across payers, not 100% overlap, but their intention is all the same, and that is that they are trying to bend the cost curve through payment for value. Now, they approach it a little bit differently, but if the process put in place by the hospital and practice addresses value and not fee-for-service first in its entirety, I would suggest that it would probably hit the majority of things. What I feel like is we have backed into it. That's sort of the conversation of, we started out as a transactional fee-for-service clinic, and we go along and we take that methodology and we keep applying one off and one off and one off and one off, and that's not going to be sustainable. You've just stated that. That is very hard to continue to do and be good at it. That's that area of clinical variation. How many different, and maybe that's not the right phrase, but that's the way I read it, that we can't keep practicing 10 different ways to document for a patient. we must be robust for every one of them consistently and hit 90% of what that is. And so that's wrapped up in a lot of work. That's the adoption of the electronic medical record. That's the lack of adoption of interoperability. That's the huge variation of, even though you have an EMR, that you may customize it, document it in different places, and it not show up in the report even if you're doing the work. And then that goes beyond how do you know what's showing up or not. So all of those things have been worked on in part and parcel, but we haven't really closed the loop for everybody. And I mean, that's one of the things I'm very interested in seeing done, is that instead of offering solutions that are another one-off, that's not tying the loop in its entirety, is what has to happen next. And so, I mean, I hear what you're saying, and I'm hoping that we can continue to have conversations with your guys' input to, start a dialogue around that. So thank you. And I agree.
Thanks. No, I was just pointing out it's just at the moment, I mean, I agree, it's all in flux, and at the moment that flux, everyone talks about the smaller hospitals being nimble, and I agree, but the problem is that there's so much flux now and they have such small staffs. I don't know how nimble they can be at this particular moment.
Right. So I think it can't be compounded. I mean, it's too hard. So, what is the solution? I don't know, but I have some ideas. Well, excellent. Thank you again. That was a good conversation. Any other thoughts? Well, with that, I appreciate everyone attending. I look forward to next week. As we said, we'll do it at the standard time rather than the time we had changed, 2 o'clock Central. And I look forward to having good conversations with you for the next 4 weeks.
Yeah, awesome. Well, thank you very much, Shannon. So as Shannon mentioned, we'll have the next week's webinar, same time, same place, 2 p.m. Central. Here, look for the webinar recording as well as the slides and presentation on the external SharePoint page. Andy will send out the email notice with the recording and the slides just as soon as they're ready, as well as a reminder that our meeting will be 2 p.m. Central next week. And then just another quick reminder that the Task 90 webinar will be Thursday the 15th at 2 p.m. and that will focus on COPD and all of the resources and efforts that have been cooking here within TASK at the National Rural Health Resource Center up to this point. Please let us know if you have any questions. Thank you guys for taking the time. Thank you, Shannon, and we'll see you next week.
Thanks, everyone. Thanks, Kayla.